is unable to be with us today, but I'm pleased to say that Norman is with us and Adrian is with us, so they hopefully will be commentating on the content of what you're about to see. But I can also tell you that we are preparing 2 more sessions for a summer series, so we'll be doing those in May and June, and we're going to discuss the functionally univentricular heart and hypoplastic left heart syndrome. But for today, we're going to talk about transposition. So Sasha, let's get going with transposition. Well, good afternoon to you all again, ladies and gentlemen. This is the final session of our spring series, but we hope to start again with another couple of sessions in May and June. So to finish this series, Diane and I are going to share with you our thoughts, as you see, on what is transposition. Well, the picture that you see is the first example of which we are aware of an illustration of transposition. This is a picture that was made by Matthew Bailey, an English doctor. He published this picture as long ago as 1796. Now, Matthew had no problem in describing it, since he called it a singular anomaly. And as far as we are aware, he was correct, because as I've already indicated, this is the first example of an illustration of this entity. But the arrangement that we're going to be discussing today is very clear-cut. So now I'm going to ask Diane to start our session by sharing with you the morphological features of the lesion that we call transposition.
If we look at this heart with transposition in attitudinally appropriate fashion, here we see the triangular tip of the morphologically right atrial appendage with its broad junction to the venous component, so that there is the superior cave vein entering its roof, looking inside. Here we have the pectinated atrial appendage, the oval fossa, and you can see the tricuspid valve guarding the inlet of the morphologically right ventricle with its coarse apical trabeculations and trabeculated septal surface. Looking at the outlet from this morphologically right ventricle, we see that it is the aorta supported within the outlet. There is the right coronary orifice, and the left is just over here near the cut. And we see the brachiocephalic vessels arising from the aortic arch, which extended to the left in this case. Looking at the outside of the left atrial appendage, it is morphologically left with a tubular appendage and a narrow junction to the venous component. So we have concordant atrioventricular connections, as we see the mitral valve guarding the inlet of the morphologically left ventricle. Here you can see the coronary sinus at the left atrioventricular groove. The morphologically left ventricle has fine crisscrossing apical trabeculations with a smooth septal surface towards the outlet. Within the outlet, we see the pulmonary valve. The left pulmonary artery has been opened here, and the right pulmonary artery is extending behind the aorta, the right lung with the arterial duct connecting to the aortic arch. If we go back to the right ventricle, we see that the aorta is supported by a complete muscular infundibulum, while in the left ventricle, the pulmonary valve is in fibrous continuity with the pulmonary or the anterior leaflet of the mitral valve. Going back to that attitudinally appropriate format, from the outside of the specimen, we see that the aorta is anterior and right-sided relative to the pulmonary trunk.
So you've seen the morphologic features of this entity. and we can all recognize the lesion when we see it. So why have there been so many problems over the years in understanding and agreeing on how best to account for this lesion? And the problems have all related to the way in which we define it. And arguments have raged over the years as to whether we should define the entity on the ventricular origin of the arterial trunks, or whether we should be looking at the relationship between the intrapericardial aorta, the intrapericardial pulmonary trunk, and then further controversy as to whether we should include details of the infundibular morphology. Now, there's a problem in these things because they are not all there at the same time. The features are mutually independent. So the first thing we have to do is to agree amongst ourselves as to which is clinically most significant. I hope you will all agree with me that there is no question but that most important clinical feature is the ventricular origin of the arterial trunks, because that is what makes the blood go round. So what we are talking about is hearts, as Diane has shown you, in which the aorta arises from the morphologically right ventricle, and the pulmonary trunk takes its origin from the morphologically left ventricle. In other words, we're talking about discordant ventricular-arterial connections. So why do we have problems? Because, as you've already seen, it's easy enough to diagnose the presence of discordant ventricular-arterial connections. The problems relate to traditionally it has always been demanded that the aorta, though it was arising from the morphologically right ventricle, it had to be anteriorly located. And for many years, not only did the aorta have to be arising from the morphologically right ventricle, it had to be supported by a completely muscular infundibulum. But that is not always the case. And a big problem arose in 1970 when Richard van Praagh came across a heart looking like this. So if you look at this heart, you see that there is the aorta, and it is located posteriorly and to the right. If you look then very carefully, the incision shows you that the aorta is arising from the morphologically right ventricle. And there we have another incision which shows us that the pulmonary trunk is arising from the morphologically left ventricle. In other words, the arterial roots are arising from morphologically inappropriate ventricles. They are fulfilling that diagnosis we have just agreed upon, discordant ventricular-arterial connections, but they are normally related. The aorta is not anteriorly positioned. And the finding of this lesion produced great problems for those who demanded that the aorta had to be anteriorly positioned before it could be described as being transposed. And there are then further problems. This is one of the hearts that we have in the Birmingham archive. And here again, the aorta is posteriorly located, arising from the morphologically right ventricle. There you see it. You can tell it's the aorta because one of its sinuses is giving rise to the left coronary artery. And there is an outlet ventricular septal defect. It is opening to the right ventricle between the limbs of the septomarginal trabeculation. But again, in this heart, there is aortic to mitral fibrous continuity. So here again, we have a heart that satisfies the criterions of transposition, because if we look at the other side of the heart, here the morphologically left ventricle giving rise to the pulmonary trunk. Another problem, because here there is an infundibulum in the morphologically left ventricle. But again, we have discordant ventricular-arterial connections. So what about infundibular morphology? You've now seen that hearts can be found with discordant ventricular-arterial connections and, by bilateral infundibulums. So in clinical terms, these individuals do have transposition. So let's look at this again now. Diane now is going to show you another example of a heart in which, despite discordant ventricular-arterial connections, we have that feature that tells us that the arterial trunks are transposed.
This specimen with transposition has usual atrial arrangement. There's a morphologically right atrial appendage on the right and a morphologically left atrial appendage on the left. The artery arising from the right ventricle is the aorta. There we can see the brachiocephalic arteries branching from the arch. And when we open the aortic valve, here we can see a coronary orifice, which gave rise to the circumflex coronary artery, and the left coronary orifice has been transected in part, but you can see where the right coronary is branching from that short segment of left main coronary artery, and it extends around the anterior aspect of the aorta. The point that we need to make in this specimen is that the aorta is supported by a complete muscular infundibulum as it arises from the ventricular mass. And when we look at the pulmonary trunk and pulmonary valve as they arise from the left ventricular mass, we see that there is a complete muscular infundibulum supporting the pulmonary valve within the left ventricular outflow tract. You'll note that here is the mitral valve, pulmonary valve, and there is no potential for fibrous continuity between the two of them, secondary to the complete muscular infundibulum. This is all a mid-muscular ventricular septal defect. The important point here is that even though we have bilateral subarterial muscular infundibulums, the ventricular arterial connections remain discordant.
So the clinically important feature, I hope we will all agree, is the ventricular origin of the arterial trunks. In other words, discordant ventricular arterial connections. We've now emphasized that to you. The aorta is arising from the morphologically right ventricle. The pulmonary trunk is arising from the morphologically left ventricle. But what we haven't mentioned thus far is the influence of the connection between the atrial chambers and the ventricles. So let's look at the influence of the atrioventricular connections. And Diane's going to start by showing you an example in which the atrioventricular connections are concordant, yet still there are potential problems. And she's then going to contrast that with other examples where there are discordant atrioventricular connections, but not what we would call regular transposition.
This specimen has transposition with usual atrial arrangement. So on the right, we can see our morphologically right atrium and its appendage. And to the left, we can see the morphologically left appendage and the left atrium with the pulmonary veins draining to its roof. If we look inside of the right atrium, here we can see an associated malformation that is sometimes seen where there's a total deficiency of the flat valve at the floor of the oval fossa, creating this atrial septal defect. Specimen has concordant atrioventricular connections so that the morphologically right atrium is connected to a morphologically right ventricle with the tricuspid valve in its inlet. The right ventricle has coarse apical trabeculations, and the aorta is supported by a complete muscular infundibulum. You'll also note in this specimen that there can be different arrangements of the arterial trunks as they arise from the ventricular mass. This specimen has the aorta anterior and leftward of the pulmonary trunk. Here you can see the right coronary artery crossing in front of the pulmonary trunk to reach the right atrioventricular groove. There are the brachiocephalic arteries exiting the arch, which extends to the right. The left atrioventricular junction has not been opened, but you can see the nice coronary sinus running within the left atrioventricular groove. And when we open this dilated left ventricle, you can see a morphologically mitral valve within the inlet. And here are the apical trabeculations, which are fine and crisscrossing, and you see the septal surface becoming smooth towards the outlet. There was a tiny muscular ventricular septal defect in this specimen that has now closed. The pulmonary trunk and pulmonary valve are within the left ventricular outflow tract, and you can see that there is mitral to pulmonary valve fibrous continuity. There is the left pulmonary artery. So that this specimen has concordant atrioventricular connections with discordant ventricular-arterial connections. This specimen was a cardiac explant, so the majority of the atriums have been resected on the short axis, but we can still see on the right side that there was a morphologically right atrial appendage with pectinate muscles around the right atrioventricular junction, and there was a tubular left atrial appendage with a narrow junction to the atrial vestibule, and that atrial vestibule is smooth all the way around. Here also is the coronary sinus running within the left atrioventricular groove, and you can see where the mouth of the coronary sinus is draining into the right atrium. Looking at the arterial trunks as they exit the ventricular mass, this is the pulmonary valve or the pulmonary trunk, and here is the aorta. You can see that there is one coronary arising there and a second arising here. Looking at the front of the specimen, there is an incomplete or rudimentary right ventricle, and the aorta is within the outlet of that small right ventricular chamber. There is significant hypertrophy, but there are coarse apical trabeculations, and the aorta is supported by a complete muscular infundibulum, so that this is not purely an infundibular chamber. It is only missing one of its components, which is the inlet. So we have an apical trabecular component and an outlet. There is a large ventricular septal defect in this particular case. There is a double inlet to this left ventricle. And here you can see the left atrioventricular valve and right atrioventricular valve into this dominant left ventricle. Here is the other aspect, or the anterior aspect, where you can see the atrioventricular valve on the left is straddling and overriding the crest of the ventricular septum. The important point here is that there is usual atrial arrangement, but discordant ventricular-arterial connections, so that the aorta is arising above the incorrect ventricle, as is the pulmonary trunk. This is another example of a specimen with usual atrial arrangement and discordant ventricular-arterial connections. I've dissected portions of the right and left atriums away, and I'm opposing their edges just to show you that we do have usual atrial arrangement, so that this is the blunt triangular tip of the right appendage with the broad junction with the venous component. And on the left, you can see the tubular appendage that is characteristic of a morphologically left atrium. If I remove that portion, you can see that the base of the right atrium can be lifted off of the ventricular mass, so there's no potential for connection. On the right, in this heart with the classical type of tricuspid valve atresia, you can see the aorta is here with that right coronary running within that deep right atrioventricular groove. The right ventricle is hypoplastic and it lacks its inlet. It has a coarse apical trabecular component and an outlet component, which is supporting the aorta. So we saw that right coronary on the outside, there's the orifice, and there is the left coronary orifice there. There is a subaortic ventricular septal defect And you can see that it is supported by a complete muscular infundibulum. This portion of the muscle is pushed posteriorly, which in this specimen is giving us pulmonary atresia. When we look at the short axis, here you can see the morphologically right atrium, the morphologically left atrium, the aorta arising from the morphologically right ventricle, and there is the atretic pulmonary valve arising above the morphologically left ventricle, which is the larger of the two ventricles. So this specimen has usual atrial arrangement with discordant ventricular-arterial connections.
So what you've now seen is transposition having discordant ventricular-arterial connections with concordant atrioventricular connections, yet an example in which, despite the aorta arising from the morphologically right ventricle with usual atrial arrangement, the aortic root was left-sided relative to the pulmonary trunk. I'm sure you all know that that arrangement with a left-sided anterior aorta is much more usually found when we have discordant atrioventricular and discordant ventricular-arterial connections, and we call that combination congenitally corrected transposition. We can also have discordant ventricular-arterial connections when the atrial appendages are isomeric, and then we have mixed atrioventricular connections, but still we can have transposition. And then Diane has shown you that we can have transposition in the setting of double inlet left ventricle, and we can have transposition when one atrioventricular connection is absent, in the example that you've seen with tricuspid atresia. So we need to come back and we ask, what is the default option for the lesion we're going to call transposition? And I would suggest to you that the default option is the combination discordant ventricular-arterial connections with concordant atrioventricular connections. And we can simply call that combination transposition. And for all those other variants, we can give specific descriptions such as congenitally corrected transposition, transposition with double inlet ventricle, or transposition with tricuspid atresia. So now let's look in a little more detail at our default option. Because what we are talking about in most instances is the blood going from the morphologically right ventricle through tricuspid valve into the morphologically right ventricle, and then out the aorta. So we have the circulations in parallel rather than in series, because the blood going out of the aorta is going to come back to the morphologically right atrium. And so on the other side, we have the morphologically left atrium pumping into the morphologically left ventricle, into the lungs, and then of course the blood is going to come back to the morphologically left atrium. So here we have the essence transposition, in this instance with usual atrial arrangement. But then we have to recognize that we have the entire situation in mirror-imaged fashion. So again, we can have these circulations in parallel rather than series when we have morphologically right atrium on the left, pumping to the morphologically right ventricle on the left, and into an aorta. And in this instance, in most, usually the aorta will be left-sided. And so on the other side of the heart, it's right-sided, at the morphologically left atrium, bumping into the morphologically left ventricle, also right-sided, into the pulmonary trunk, the two circuits being in parallel rather than in series. So let's now look at these two major subsets. Diane's going to compare for us the arrangements where we have the typical arrangement, the usual atrial arrangement, and then a much rarer variant with multiple additional components in the setting of mirror image arrangement of the atrial chambers.
What we usually see associated with transposition is usual atrial arrangement. And using sequential segmental analysis, you can account for all of the different segmental connections that you might see in any heart, for that matter, with congenital heart disease. Here we see the blunt triangular tip and the broad junction with the venous component, telling us that this is a morphologically right atrial appendage. There's the superior cable vein entering the roof of the right atrium. Here within the appendage, you can see those pectinate muscles towards the screen and the pectinate muscles that extend to the crooks of the heart. Here's our coronary sinus, and there is the oval fossa. Within the inlet of the right ventricle is the tricuspid valve, and it is a morphologically right structure. The morphologically right ventricle, you can see, has its characteristic coarse apical trabeculations and a trabeculated septal surface. Within the outlet of this morphologically right ventricle, you'll see that we have the aorta, which is supported by a complete muscular infundibulum. There are the brachiocephalic arteries branching from the arch. And here is the right coronary, and the left coronary artery is over here near the cut in the aortic wall. So on the right side of the heart, we have concordant atrioventricular and discordant ventricular-arterial connections. On the left, here is our narrow or tubular appendage with its narrow junction to the venous component, where the pulmonary veins are draining to the roof of the left atrium. The left atrial vestibule is entirely smooth. Here is the horseshoe that designates the left side of the atrial septum. So this is the left side of the flat valve at the floor of the oval fossa. There's our narrow junction of the left appendage with the pectinate muscles confined to that appendage. Also telling us that this is a left atrium is the coronary sinus within the left atrioventricular groove. The mitral valve is guarding the inlet of the morphologically left ventricle, which we can see has fine crisscrossing apical trabeculations and a smooth septal surface towards the outlet. Within the outlet is the pulmonary valve, and here we can see there is fibrous continuity between the mitral valve and the pulmonary valve. So on the left side, we again have concordant atrioventricular connections and discordant ventricular-arterial connections. You can see the left pulmonary artery branching here, and there's the arterial duct. I will mention also that this specimen has right-handed ventricular topology, so that only the palm of my right hand can be placed on the septal surface with my thumb in the inlet and my fingers in the outlet. This specimen also has transposition with concordant atrioventricular connections. You'll note that the apex of the heart is pointing to the right in this case, and we'll see that using the morphologic method along with sequential segmental analysis will allow us to mark all of the within this specimen. If we look to the left, we see the superior cable vein and the inferior cable vein entering this morphologically right atrium with its broad junction to the venous component. And you'll note that the tip of the appendage is triangular or blunt. Looking inside of the right atrium, you can see those pectinate muscles, which do extend all the way to the crooks of the heart. There's also a so-called secundum type of atrial septal defect with only a small component of the atrial septum remaining, so that this specimen does have an unbalanced atrioventricular septal defect and a common atrioventricular valve. So here you can see I'm entering from the right atrium into the morphologically right ventricle that has coarse apical trabeculations. So we have concordant atrioventricular connections. The aorta arises from this morphologically right ventricle. Here you can see the brachiocephalic arteries arising from the arch, which extends to the right in this case. If we look at the left, or I should say the morphologically left atrium, which is on the right side in this heart, we see the tubular appendage with its narrow junction to the venous component where we can see the pulmonary veins draining into its roof. There is the so-called secundum type of atrial septal defect and the small remnant of the atrial septum. So from this morphologically left atrium, I can probe into this tiny morphologically left ventricle, which is located just here. You can see the crest, the scooped out crest of the ventricular septum, and that this common atrioventricular valve is supported on the right side and within the morphologically left ventricle by a solitary papillary muscle. The pulmonary trunk was aligned with this hypoplastic left ventricle or morphologically left ventricle, and you can see that it is posterior and rightward of the aorta, which is leftward of the pulmonary trunk. Also, I should emphasize that unlike the last specimen with concordant atrioventricular and discordant ventricular-arterial connections, this specimen has left-handed ventricular topology, so that if I place my hand on the septal surface, I can only place the palm of my left hand on the septum with my thumb in the inlet and my fingers in the outlet.
So now, having seen all that, we must ask whether detransposition is a suitable synonym for the lesion we would much rather call simply transposition, because I'm sure there are many of you who call the lesion detransposition. So let me show you another example of the lesion you've already seen. The heart that Diane showed you when comparing the influence of the atrioventricular connections was a heart such as this. The aorta in this instance is anterior and it is left-sided relative to the pulmonary trunk. We can see it is the aorta because it's giving rise to one of the coronary arteries. But as in the example that Diane showed you, this is a heart that has usual atrial arrangement. So here we have L transposition, but it is not congenitally corrected. This is transposition S, standing for soletus, D, pulmoventricular looping, L, left-sided aorta. So those of you who do still use Van Praaghian terminology, and I know there are many of you, you must, when you are describing transposition, give the full segmental notation. So regular transposition is SPD. The mirror image variant, which Diane showed you, is ILL. It is L transposition, but it is not congenitally corrected. And then the example I just shown you, along with the heart, previously seen shown to you by Diane, transposition SDL is again regular transposition. It is not congenitally corrected. L transposition is not the same thing as congenitally corrected transposition, just as D transposition is not the same for regular transposition, since transposition IDD is congenitally corrected. So now we know what we're talking about. Let's look at the variables that we find within this phenotype. And there are many. Diane showed you a very complicated example, but we can concentrate on the integrity of the ventricular septum, the obstruction within the left ventricular outflow tract, the arrangement of the coronary arteries. They are the three features we're going to concentrate upon, but do remember that there can be many other associated malformations. So let's start off by looking at the integrity of the ventricular septum. And Diane's going to show you an example in which the ventricular septum is intact. And then she's going to compare that to a heart with a ventricular septal defect.
We've seen this specimen in the past, and we know that it has usual atrial arrangement and transposition with the aorta anterior and rightward of the pulmonary trunk. We're going to look at the ventricular septum, which in this specimen is intact. You'll note that the morphologically right ventricle has coarse apical trabeculations as well as a trabeculated septal surface. And very often VSDs are not easily recognized from the right ventricular side because of these coarse trabeculations. The component in this specimen is also intact. The aorta, again, is arising in the ventricle above a complete muscular infundibulum. If we look at the interventricular septum from the left, there you'll see fine crisscrossing apical trabeculations and that smooth surface as it extends towards the outlet. Here is our mitral to pulmonary valvar fibrous continuity. And you'll note that that muscular interventricular septum is intact, as well as the membranous septum being intact. If we look at another heart with transposition and usual atrial arrangement, you'll note that the aorta is in a much more directly anterior position relative to the pulmonary trunk. And this shows us that the arterial trunks can rotate around one another in hearts with transposition as they exit the ventricular mass. This specimen has a perimembranous ventricular septal defect, and it is an outlet defect. By that, I mean that it lies between the limbs of the septomarginal trabeculation. The septomarginal trabeculation is here with its cephalic limb extending up to become part of the subaortic infundibulum. And typically the caudal limb joins the inner heart curvature and gives rise to the medial papillary muscle. In this case, that medial papillary muscle is very hypoplastic. This specimen has a fibrous posterior inferior border secondary to the deficiency in that caudal limb of the septomarginal trabeculation, so that the tricuspid valve and the mitral valve are in fibrous continuity with one another along that posterior inferior border, rendering this defect perimembranous. If we look at the defect from the left side, we can see the pulmonary to mitral valve fibrous continuity, and as well along that posterior inferior border, the tricuspid to mitral valve fibrous continuity. This area is the important region for the surgeon because of this fibrous border relative to the conduction tissues, which we'll mention shortly.
So, Diane has shown you an example in which the ventricular septal defect was perimembranous. And many times when you have such perimembranous ventricular septal defects, there is malalignment of the muscular outlet septum, although that was not an obvious feature in the heart that Diane showed you. We can also have muscular defects. They can be anywhere within the ventricular septum, as they can in hearts with concordant ventricular-arterial connections. And we use exactly the same system, except we have to remember that in the setting of discordant ventricular-arterial connections, it is the pulmonary valve that is coming out of the left ventricle. And much more rarely we can find examples where there is fibrous continuity between the leaflets, pulmonary and the aortic valves, making the defect doubly committed and juxta-arterial. But the basic rules that we have for describing the septal defects are the same as they are for hearts having concordant atrioventricular and concordant ventricular-arterial connections. So Diane's going to emphasize that now by showing you another series of hearts comparing the situation of muscular and perimembranous defects.
We've already looked at this specimen with a perimembranous ventricular septal defect that extends into the outlet component of this right ventricle. And what I'd like to do is look into the right atrium to show you the landmarks that mark the apex of the triangle of Koch that will lead us to the site where our atrioventricular conduction axis will be located. So here you can see the flap valve at the floor of the oval fossa. This is the right atrial appendage, and there's the tricuspid valve orifice. So the first limb or arm of the triangle of Koch will be the tendon of Todaro, which is a fibrous structure that runs in this eustachian ridge. The second arm will be the hinge point of the tricuspid valve, and at the base of the triangle is the mouth of the coronary sinus. So at the apex of this triangle is where our atrioventricular conduction axis will be located. This AV node will extend to become the penetrating bundle or the bundle of His, and that will give rise to the right and left bundle branches. If we look at the borders of this ventricular septal defect, we know from the previous description that it extends to become very membranous along the posterior inferior border, where there is fibrous continuity with the tricuspid and mitral valves. The caudal limb of the septomarginal trabeculation does not reach the inner heart curvature in this heart and gives rise to this very hypoplastic papillary muscle or medial papillary muscle. If we anticipate the site of our atrioventricular conduction axis, I can place the tip of my probe there and draw a line to the medial papillary muscle. And this is where the right bundle branch will emerge relative to the medial papillary muscle and extend along the septomarginal trabeculation. If we look at the left component of this defect, here we can see our arterial to atrioventricular valve fibrous continuity and where the right fibrous trigone is located, so that this is where the mitral valve is anchored within the roof of the left ventricle. And we can also see that fibrous continuity along the posterior inferior border between the tricuspid and mitral valves. So that the left bundle branch will emerge in this area and extend along the crest of the septum and trifasciculate over the ventricular septum. So for the surgeons, this posterior inferior border is the danger zone when it comes to the conduction tissue, and they must be very careful where they place their sutures when repairing this ventricular septal defect. I have another specimen that has an outlet ventricular septal defect, but we'll see that this one is entirely muscular. This specimen has the free wall of the aorta, the right ventricle, and the right atrium removed. You can see there's an atrial septal defect, and there is the mouth of the coronary sinus. So this is the septal leaflet of the tricuspid valve. And if I pull it back a bit, you can see that that caudal limb of the septomarginal trabeculation, in this case, reaches the inner heart curvature or that ventriculo-infundibular fold. And you can see the medial papillary muscle here arising from it, so that the borders of this defect are entirely muscular, and it is an outlet defect because it extends between the limbs of the septomarginal trabeculation. So we can anticipate the apex of the triangle of Koch here. And again, the same rules apply. If I draw my a line from the tip of my probe to the medial papillary muscle, this is right where your right bundle branch will emerge and extend along the septomarginal trabeculation, so that the muscular bar along the posterior inferior border is protective of the conduction tissues. This specimen is actually quite interesting on the left side, and here you can clearly see that muscular bar along the posterior inferior border. And if I put a light behind here, you can see where the membranous septum is located relative to that muscular bar, and also appreciate that here by my thumb, there is some muscle extending beneath that pulmonary valve, so that there is only a short fibrous continuity between the arterial valve and the atrioventricular valve in this specimen. And the membranous septum is quite a bit away from the base of the pulmonary valve, so that where the membranous septum joins the right fibrous trigone marks the central fibrous body, and that's the area where the left bundle branch will emerge and extend along the crest of the septum and trifasciculate over the septal surface of the left ventricle. So you can see that this muscle bar along the posterior inferior border is quite protective of the conduction tissue when you have a muscular ventricular septal defect. But I will make the point that the same rules apply whether you have a muscular or a perimembranous defect And the surgeons know where they have to be more careful when you have a perimembranous ventricular septal defect.
So then, the next feature, obstruction of the left ventricular outflow tract. Now that can be valvar. Have valvar obstruction, be the septum intact or deficient. But a particularly important feature in the setting of a ventricular septal defect is caudal deviation of the muscular outlet septum. There can also be bulging of the ventricular septum, and that can be made much worse by the presence of a fibrous shelf. And very shortly, Diane will illustrate to you fibrous shelf. We can also have tissue tags. We're not going to be looking at this, nor are we going to be looking at abnormal arrangements of the tension apparatus. But what we are going to see is how there can be fibrous shelf producing obstruction in the setting of an intact ventricular septum. But then Diane's going to emphasize to you the important variant in the setting of a ventricular septal defect, caudal deviation of the muscular outlet septum.
This specimen with transposition is following a cardiac transplant. The patient previously had an atrial switch procedure, and I'm not sure if it was the Senning or the mustard, but here you can see the aorta anterior to the pulmonary trunk and the left and right coronary arteries arising from the aorta, and incidentally they arose from the same sinus in this specimen. Here, the pulmonary valve is within the left ventricular outflow tract, and you can see this fibrous shelf beneath the valve. This is the only specimen I have with such a fibrous shelf, so that it is not a very extensive one, but it still shows you some of the anatomy in that it can extend onto the arterial valves as well. In many specimens, it extends also on to the mitral valve. In this case, it does not. These fibrous shelves can become quite thick and even form a tunnel-like outlet within the left ventricle. As I mentioned, this one isn't so extensive, but you can see how elongated they can be, and they can, as I said, become quite thick. If we look at another specimen within the substrates of left ventricular outflow tract obstruction, this specimen shows us a hypertrophied right ventricle with the aorta arising directly anterior to the pulmonary trunk. There is a perimembranous ventricular septal defect that extends into the outlet component of this morphologically right ventricle. And you also note that the subaortic infundibulum is not very elongated or thick, and that there is posterior deviation of the outlet septum in this specimen. When we look at the left ventricle, kind of up the barrel of the ventricle, so I have the apex pointing upwards, and I've opened this in a clamshell fashion. So here you can see the left ventricular outflow tract. This is the anterior or the pulmonary leaflet of the mitral valve. And here you can see that muscular ridge or that posteriorly deviated outlet septum. This posterior deviation causes significant left ventricular outflow tract obstruction, and often these pulmonary valves are stenotic, and this one in particular is bicuspid. There's one intact leaflet and the other has been bisected when this pulmonary trunk was opened. But you can note this muscular ridge here with a bit of fibrous tissue along its edge, causing severe left ventricular outflow tract obstruction or pulmonary stenosis in a case of transposition. Also note that this ventricular septal defect that is quite large is perimembranous because we have this extensive area of tricuspid to mitral valve fibrous continuity.
So now let's move on to the feature that has achieved great clinical significance with the advent of the arterial switch procedure. Because the surgeons now need to know the origin of the coronary arteries. And we know that, almost without exception, the coronary arteries arise from the aortic root, but they do so from the sinuses of the aortic root that are adjacent to the pulmonary trunk. But I'm sure you all know the arrangements are not always the same. There can be varied origin of the three main coronary arteries: right coronary artery, the anterior interventricular artery, the circumflex artery. And if we are properly to account for that variation, we need to distinguish between those two sinuses that are adjacent to the pulmonary trunk. So here you have the situation looking down on the base of the heart from above. I will show you an example of this looking down on the root very shortly. But here you're looking down, the aorta is to the front, the left side of the heart is to your left hand, the right side is to your right hand. But what I want to emphasize is that the coronary arteries are arising from the two sinuses of the aortic root that are adjacent to the pulmonary root. So how do we distinguish between these adjacent sinuses of the aortic root? And we do so using the so-called Leiden convention. And let me illustrate to you the Leiden connection, first of all, in the normal heart, because the Leiden convention depends upon the individual looking at the coronary arteries, here depicted as a small coronary cardiac surgeon. The surgeon is standing in the non-adjacent sinus here of the aortic root and is looking towards the normally positioned pulmonary root. And then standing in the non-adjacent sinus, looking towards the pulmonary root, we see the two sinuses that are adjacent to the pulmonary root. And it follows one of those sinuses is to the right-hand surgeon. And we call that sinus number 1. And in the normal heart, that right-handed sinus gives rise to the right artery. It then follows that the other sinus is to the left hand, the surgeon. We call that sinus number 2, and it gives rise to the left coronary artery, which divides into the circumflex artery in the normal heart and the anterior interventricular artery. So what is the situation in transposition? Well, in 2/3 of cases, you have the situation as we see here. Now, of course, the aortic root is anterior relative to the pulmonary root in almost all instances. So we are seeing the back of our surgeon who is looking towards the pulmonary root. Still, however, one of the adjacent sinuses of the aortic root is to the right hand of the surgeon. And we still call that sinus number 1. But in the majority of cases for transposition, that right-handed sinus, sinus number 1, gives rise to the main stem of the left coronary artery. And that then divides, in most cases, but as we'll see in all, into the circumflex and the anterior interventricular arteries. So the other sinus still is now to the left-hand sinus of the surgeon. We still call that sinus number 2. And in the majority, but not all cases of transposition, it gives rise to right coronary artery. Once we have determined and worked out how we can distinguish between the sinuses, we can then describe how best to account for the varied origin of the 3 major coronary arteries. And Diane is now going to show us how to distinguish between those sinuses, and she'll show us 2 variants.
We're going to look at this heart with transposition from the short axis, so that this would be the sternocostal aspect. Here you can see the right atrial appendage, the left atrial appendage, and the transverse sinus. This is the aorta directly anterior to the pulmonary trunk. And if we look at the coronary arteries based on the Leiden convention, the observer will stand in the non-adjacent aortic valvular sinus relative to the pulmonary trunk. And then the right coronary artery will arise from the left hand facing sinus or sinus number 2, while the left coronary artery will arise from the right hand facing sinus or sinus number 1. Here you can see the right coronary progressing into the right atrioventricular groove, and there is the sinus node artery extending up to supply the sinus node with oxygenated blood. The left coronary has a very short common artery where it then immediately bifurcates into the anterior interventricular and the circumflex branches, which the circumflex is extending over to reach the left atrioventricular groove. The other interesting thing in this specimen is that there is so-called commissural mismatch, so that you can see the commissures within the aortic root, and here you can see them within the pulmonary root. And you'll note that this aortic commissure extends to the mid sinus of the adjacent pulmonary valvar sinus and not matching up with the commissures within the pulmonary root. So this is one of the concerns when surgeons have to move the coronary arteries, although these days they are very good at that and can usually work around it. If we look at another heart with transposition and look at it from the short axis again, so here the aortic window we can pull back and look at the aortic valvar sinuses. So this is the non-adjacent sinus here relative to the pulmonary trunk, which lies immediately posterior to the aorta in this case. And then we can see the left-hand facing sinus, which gives rise to the right coronary artery, and the right-hand facing sinus, or sinus number 1, which gives rise to the left coronary artery. In this case, the left coronary artery consists only of the anterior interventricular artery, because the circumflex artery, when we look through or into the transverse sinus, you can see that the circumflex artery is arising from the right coronary artery, traversing posterior to the pulmonary trunk into the left atrioventricular groove. The right coronary artery, you can see, extends to the right atrioventricular junction, and from that bifurcation, also we have the artery to the sinus node. So this has the circumflex coronary artery running in the transverse sinus and arising from
Sorry, guys, I think Sasha lost connection. We are just going to restart in a minute. Sorry for that.
Right coronary artery, sinus number 1, the right-handed sinus gives rise to the circumflex and the anterior interventricular arteries. Well, I'm showing you here the analysis we made a long time ago of 100 hearts of Pittsburgh. And you see that in those hearts, if you add the numbers together, 66 of those, 66 of those hearts, 2/3 had that regular pattern. And then another 16%, 1/6 of them had the second pattern that Diane showed you, in which the circumflex artery arising from the left-handed sinus took a retropulmonary course. But there are many other variants. All of the arteries rise one of the sinuses. We can have these additional variations, but we can account for all of them simply by distinguishing between the sinuses and then describing from which sinus arise right coronary artery, circumflex artery, the anterior interventricular artery. But there is then one particular variant that the surgeon needs to be aware of, and that is the variant I'm showing you here in a drawing. So here is the right-hand sinus, sinus number 1, and to all intents and purposes, it looks as though that anterior interventricular and circumflex artery, the main stem of the left coronary artery, is going to take origin from that right-handed sinus. But in fact, it does not. It crosses over the commissure between that sinus and the pulmonary trunk and it arises, sinus number 2, along with the right coronary artery. And this is the variant that is known as the intramural anomaly. And in this instance, there is intramural origin of the left coronary artery, but as we're going to see in just a moment, there can also be an intramural origin of the right coronary artery. And that is what Diane is going to show you as she illustrates this important variation, intramural origin of one of the coronary arteries.
Here's another case with transposition. So you can see the aorta arising from the morphologically right ventricle and supported by a complete muscular infundibulum. In this specimen, there are interesting coronary arteries. Here we can see the left coronary orifice, which gives rise only to the anterior interventricular coronary artery. And you can note also that it has a slightly low takeoff within the valvar sinus, so it lies below the sinusotubular junction. This second coronary orifice gives rise to the circumflex coronary artery, and it also lies a bit below the sinusotubular junction. The remaining coronary orifice is a little more difficult to see because it lies immediately adjacent to this valvar commissure, and it gives rise to the right coronary artery. So this coronary artery will have a short intramural course across that commissure, and as it emerges from the aortic wall, it will extend then to the right atrioventricular groove. So if we look at this from the transverse sinus aspect, you can see the circumflex artery here running in that transverse sinus to the left atrioventricular groove, and most likely giving rise to sinus node artery. But here you can see the right coronary artery, and there is that short intramural course where it has to cross the commissure in order to emerge from the aorta to continue on its course.
So what I hope we've shown you, and you've seen lots of hearts today, you've seen some beautiful demonstrations by Diane. She's shown you the essence of transposition is discordant ventricular-arterial connections. And to my mind, that is what we can now simply call transposition when it is combined with concordant atrioventricular connections. This is the phenotypic combination, I believe, is simply best described as transposition. But then what we've shown you, even in this variant, even in this classical variant, there are multiple associated malformations, but nowadays it's easy to identify them, just as it is to identify the origin of the coronary arteries, harder part is to describe them. I hope what we've shown you is how easy that is to do now using Leiden convention. But do remember, take note of those other variables. Haven't had time to demonstrate in any detail, including aortic relationships, infundibular morphology. They change the situation, but they don't detract from the fact that the essence transposition is discordant ventricular-arterial connections, the origin of the aorta from the morphologically right ventricle, the pulmonary trunk from the morphologically left ventricle.
Fantastic presentation. Thank you so much, Dr. Anderson and Diane. It was really, really fantastic. And guys, please type your questions on the Q&A chat box, and everybody's going to be very happy to answer. As usual, we are going to start with Dr. Silverman making his comments, and I'm sure it's going to be fantastic. And after that, I have one question that maybe Adrian or Sasha could answer. How the intramural coronary artery makes so much more difficult the surgery for the arterial switch?
Sure, I think that's very important, and I know Adrian's here, and he's also a surgeon, so I think that we need to understand in this issue, what is the trapdoor procedure? And maybe the surgeons can help us understand that. Bob, I must congratulate you. It was as clear as crystal water today. And the answer is, I think I should reiterate once again for everybody that transposition is a ventricular-arterial connection. And in transposition, it's discordant. And that's what takes care of everything. So tricuspid atresia, AV septal defects, etc., all are that issue are all transposition. The issue of double outlet, of course, is another kind of ventricular arterial connection. But within that, the double outlet transposition group, I want to ask you one question. I have several questions. So this first question is, what happens if you have an atretic valve? Can you call an atretic valve transposition or double outlet? Or should you call it a single outlet heart?
It all depends whether you can trace the atratic route to one or other ventricle. In fact, Diane showed you two hearts that she called transposition because the aorta arose from the right ventricle, and she was able to show you that the atratic pulmonary route could be traced to the morphologically left ventricle. Had the atratic route been traced, the atratic pulmonary route being traced to the right ventricle, that would have been double outlet right ventricle with pulmonary atresia. So I think we should reserve the single outlet when we are unable to trace the atratic route and when we have, when we're not sure which it's going to be. When we can positively identify the ventricular origin of that atratic route, I think it's entirely appropriate to describe it either as transposition when it goes to the left ventricle or double outlet if it and the patent aorta arise from the right ventricle.
Thank you, Bob. Bob, I wonder, can you pull up your presentation and get to Matthew Bailey's original picture for us?
It would be very difficult, Norman.
Well, okay, then everybody's going to have to remember or go back and look at this. But as I looked at Matthew Bailey's study today, a couple of things came out to me. Firstly, he was John Hunter's son-in-law. So I don't know whether he got there on his own accords or whether he became the surgeon because he was the son-in-law of John Hunter. But the thing that's most important about that picture, and I've never really looked at it because I always look at the transposition, but if you look at the atrial appendages, the appendages